good morning. Welcome to the 13th edition of the Health System Fix podcast. My name is Dr. Gaurav Mishra. I'm a child, adolescent, and adult psychiatrist and a health system design expert. My goal through this podcast is to talk to people who have different professional and personal experiences within the health system and have worked on innovative solutions. It's a pleasure today to have my friend Lucy Marrero on. Lucy is a licensed marriage and family therapist. She's a certified professional in healthcare quality and a community psychologist. She serves as the behavioral health director at Gold Coast Health Plan, which is the Medi-Cal managed care plan for Ventura County in California. She's passionate about promoting seamless, high quality, and safe care through partnerships and collaborations. We love to hear about collaborations. She serves on the Medi-Cal Voices and Vision Council, which provides insight into local health plan and member experiences to inform state policy. She's also a patient safety champion for Patient Safety US and draws from lived experience as a patient and caregiver to inform her work. Welcome, Lucy. It's great to have you on.
Thanks, Dr. Mishra.
Gaurav is great.
I know. We're on a first name basis.
Yes, of course. I'm excited to talk to you. I think you've had such a long career in healthcare, and it'll be great for people to hear about your experiences. But I like to start with early life for people. What was life like growing up till you first start thinking about a professional career or college?
My childhood, I was in the gifted and talented program when that was a thing. And so it gave me an interesting track in my life. I was aware that I had some sort of intelligence, some sort of potential for the future, but also came from a family where we didn't have anybody who'd gone to college. So it was a little bit confusing when I got to the point of deciding what to do. And I'm grateful for my mom, who is a registered nurse and finished her associate's degree as an RN at the same time that I was getting my high school diploma. So she said, get an associate's degree. That's all you need. You'll be fine. And that was sort of like the message. And that's really all I knew. I knew I was good at school, but I didn't know exactly what I had to offer to the world. So I went through some career pathways that had nothing to do with healthcare. Although I was interested in health and in well-being and in mental health, and I even had this idea, maybe I want to be a social worker. But then I also had a lot of anxiety and uncertainty about how to apply for college. I didn't think I would get accepted to a 4-year college. So I had an associate's degree for many years until I went back to school because I really just found that the work I was doing as a technical writer, writing manuals and business processes really wasn't fulfilling. And I thought, there's something more I can offer to the world. And I wasn't sure what that was, but I figured it was in social sciences and sort of process of elimination, decided, well, maybe I'll be a therapist because I can make a living that way. And I didn't know how I felt about being a therapist. I hadn't had great experiences with therapy myself. And I wasn't sure that it was actually worthwhile, but I figured I would give it a try and try to be a really good therapist. And as soon as I sat down with somebody as an associate, well, as a trainee while I was still in school, as one does when you're in your master's program, I thought, this is amazing. Like just talking with people and learning about their journeys and being able to be a witness to that journey and to be a supportive person. And I also knew that I wanted to work on systems because I'm always interested in kind of that larger view as well as that, kind of micro view. And so I have a concentration that I did in my master's program for community psychology, which has elements of kind of like a master's in public health, social work on the macro level, things like that I didn't even know about, right? I was just trying to make my way through school and figure out what job I was going to have. So as a therapist, even before I got to the point of being licensed, I was tapped by someone to be in the quality department. And I had no idea what healthcare quality was. I didn't know what I was getting into. The description of what it meant really didn't make any sense to me. As a person who was a therapist, I was like, well, my documentation is okay. I can help other people document. I had no idea what I was getting into. It started a whole, leadership journey that I'm very grateful for. But I think that early career stuff, which, was 10 plus years, in technical writing and in business processes and in telecommunications really oriented me to systems in a way that I'm really grateful for and helped me sort of organize my work as a therapist as well to think about beginning, middle, and end and how all of this sort of works together, not just the relationship with the person in front of you. That's incredibly important, but then also it's within the context of systems of healthcare.
Yeah. That's interesting because I think, my understanding of the health system came much later into my healthcare journey. Like I was very narrow focused. I wanted to be a physician from like five, probably. Like it had never changed. And when I got to do that, that was super exciting. And as you go down into medical training or clinical training, you keep going down narrower and narrower paths, right, for training and specialization. And so my view of the health system and the problem is now at a bigger scale than what I'm taught to treat. Is probably came a few years into my actual working post training. And it's interesting that your early experience, even though at that time sometimes we think, what are we doing? What are we working towards? And it all adds up over time. So that's really interesting to see that you had that early. So even going into clinical training, you already had a view of the bigger system.
Or maybe a curiosity is probably more accurate because I had no idea what I was getting into, but I wanted to understand what makes this work? What makes this a constraint? Why can't I do it this way? How do we get paid? If we got paid a different way, would that make it more possible to serve people in these innovative ways? And so I think it's that curiosity that, I think you could probably relate, right? As a mental health professional, and a helping professional, you want to know, like that curiosity really drives you, whether it's at the individual or the system.
And I don't know if it was just me. I don't think it's just me. I think medical training makes you think you're it and you are the answer to all the problems. And you feel that. And then within a few months, you realize, oh God, I don't have all the answers, obviously. And so then you start like, why don't I have all the answers? I think sometimes clinicians early in their training do struggle thinking, I can't fix everybody and everything. So having that curiosity is a great way to take that burden off a little bit and you think about the bigger system.
Yeah. That's such a good point because I do feel like our training encourages us to take the expert seat. We understand humanity and the human condition and, all of these technical, you couldn't possibly understand unless you've been trained kind of ideas. And it really is misleading. And it led me down some gnarly paths, I think, and did a little harm to people, not only as a therapist, newly, but also as a new manager, thinking about how that pressure of knowing and that pressure of doing the right thing and getting it right and getting your people, who work for you to do the right thing and do it well. And man, did I make some mistakes. And I really had to learn from them because when you try to tell people what to do, it never works.
It's such a great point. I tell trainees all the time, you're training to be a therapist, you're training to be a physician, makes you a physician, doesn't make you a good physician. That's your own personal journey. I mean, if you don't have beyond school, if you're not working on that as a physician or a psychiatrist or a therapist, if you're not working on being a good one on your training, you're not going to be a good one. And the thing about mistakes, it's such an important one for the leaders to uh, it for themselves first and then for others. And that's the only way to get through.
Yeah. It is. And I don't think we're encouraged to say, I don't know, or let's find out, or tell me more, or you're the expert in your life. I'm not. I have some tools and some questions at hand that I can bring to the journey, but I can't tell you what's best for you. And that is such a temptation and such a trust breaker in that relationship with the person we're trying to serve or the communities we're trying to serve when we don't listen to their expertise of what it's like to be a patient, what it's like to be a human being in these particular circumstances and social, economic corners and all of the realities that people live in. And when we think we've got the answer, and we blanket say, well, you know what you should do? You should try some journaling. It's so different when someone is asked what would be meaningful to you, what would make a difference for you. And that's what I really appreciated about the California Healthcare Foundation fellowship process is that human-centered design. And it's so key, I think, to the success of anything we do. Because now, I've got some really smart people on our team, and I emphasize that you have your training and your expertise and your lived experience, and those are assets to bring to bear. But who is the expert in this experience? So it's really important to involve and listen to and co-design with the people who are providing the services, the people who are being provided the service or who should be reached but we're missing. And I think that that has really changed that I have to be the expert. I have to know all the things kind of orientation that I see. It's like a temptation and it's so easy to fall into and it leads to not great outcomes. So I think it's been such a lovely thing to put that into practice with my team and see how that influences the work that they're doing. Designing programs for pregnant members who are using substances. How do we support people in their journey and support them through any stage of readiness for change, even if they're in what we would call pre-contemplation, which is, I don't have a problem. I don't need to take action. But being there for people and creating systems that can hold that space for people to come into treatment as they desire and that it serves them in the ways that they need to be served.
We can just stay on this question for the whole time. The CHCF leadership program helped me reframe the way I think about other leaders in my team,
Mm,
take the pressure off me to have all the vision and bring it to a place that we collectively have this effort and or collectively develop this vision. It's not just my vision, right? Also, it was part of the ego thing that I had to learn to kind of give up the illusion of control.
mhm.
The culture of a leader who is not vulnerable is over. The culture of leader who is more open, more vulnerable, is having real conversations with their team. That's the culture that's today in our healthcare.
It is.
Okay, you were in a MFT training, and you said even before you got licensed, you were already tapped to do quality work. You were at the Child and Family Center in Santa Clarita, and then you transitioned to Senior Director of Quality. What is that transition like in work and perspective? About clinical work, what is that like for you?
Yeah, it's such a great question. When I transitioned from being a therapist in that organization to being a leader in the organization, and first as like a coordinator, from a clinical perspective, and then eventually, a senior director in a very, relatively small organization with a very, very small leadership team. I'm grateful that I had that opportunity and that exposure to how things work, to problem solving, to figuring things out, and also to, like I said, making those mistakes of thinking, I have the answers, I'm going to be prepared, and I'm going to tell people how we're going to do things. And then being bewildered when people looked at me like, well, then you fix it. No, I need you. Why aren't you here with me? And I didn't yet have the leadership vocabulary around how to be a vulnerable leader that creates teams that have strong trust and perform well. And so I think that was my main takeaway from those years was I have to do things differently. And I don't know exactly how that looks, but I'm going to have to overcome the insecurity of, am I a good leader and am I doing a good job? And I'm going to have to shift into what I didn't think of at the time as a mindset or a stance of vulnerability, but that's exactly what it was, right? And I went from a behavioral health organization where I was a trusted leader and expert in certain areas and felt very comfortable in my role, even though I was pretty new. I was older and a lot of things made a lot of sense to me. And then I transitioned to the county healthcare agency in Ventura County in ambulatory care, so a medical setting, which was completely bewildering. And I only knew a smidge of things. And I had a lot of theory a lot of training around healthcare quality and systems and making change that I remember sitting in a meeting. I think it was the first day that I was there with two doctors and a nurse, and the physicians were physician leaders as well. So they were in roles of authority, one of them being my kind of semi boss. And they're talking about the HemaQ. And I'm just, I'm listening and I'm trying to glean from context. What is this? Is it a virus? Is it a condition? Is it a Is it equipment? Is it a process? I had no idea. And, to sit there and be Googling when you don't even know how to spell it, right? I'm trying to act like I know what I'm doing. And I really quickly realized, no, I'm just going to have to ask the dumb question, right? And hope that people don't look at me like, oh dear, why did we hire you? We should have hired a nurse, which was kind of part of the interview process was my concern about not being a medical professional, but a behavioral health professional. And I think that learning from that point of humility, from staff who knew more than I did about many different things, and just learning and listening, absorbing, asking questions, that really transformed my approach. And then being able to make system level change with physician leaders who own their own corporations. We had a number of clinics, and it was always leading by coalition building. There's no such thing as telling a physician leader of their own corporation, you're going to start screening and asking people sexual orientation and gender identity because we're going to lose money if we don't. And it's the right thing to do. Absolutely not. It's a lot more complex than that. It's a lot more nuanced. It requires a lot of difficult conversations. And I remember developing this, I guess, way of, and this appreciation for the devil's advocate, the naysayers, the people said, this is never going to work. This is dumb. It doesn't make sense. It's not clinically indicated. All of the things that people would say around these transformative things we were trying to do in the system and that millions of dollars we're riding on. It's no small pressure, right, to be in that position. But it really was so formative to teach me be humble, ask questions, find out why people don't like this idea, incorporate them into the designing of the work and the evaluation of the work, and don't hide from the people who say no, especially the people who say no loudly, right? Model that ability to say, tell me more. What's your concern? Let's talk offline. Let's bring this back. I will follow up with you, in 2 weeks to address your concern. Oh, I couldn't address your concern. I'm sorry. We're still working on it, but it's important feedback to me. And seeing those relationships transform into results. And being in the high performing tier in California was very much, and it wasn't like it was single handedly me, it absolutely was not. I had a very strong physician leader that we worked alongside, great teams, but really orienting teams towards understanding and learning and growing together and being accountable and asking people to be accountable with you for their piece of it taught me so much that I'm so grateful for, because if I had not figured out that humility factor from the beginning, I think I would have probably been asked, thanks so much, but your results are really terrible, and out you go.
Right. Over the years, I've been thinking through when I'm bringing on people working on projects, what are two characteristics which are most critical? Courage and humility, to me, I think, feel the most critical because you have to be willing to jump in a very difficult problem. And you also have to be humble enough to say, I don't know this. I'm going to figure it out. I want to learn from everybody around me, no matter where they are in the hierarchy of healthcare, especially in a new position. Anybody around me who's been there even a month longer than I have has something to teach me about the system. And when you're working with stakeholders, it is so important to lead with empathy with the people you disagree the most.
Hmm. Oh gosh, I love that. Yeah.
Because that's really where your effort is most. Well, as you said, the loudest naysayers are the one you don't have to just engage with them. You have to actually lead with empathy. Why is this person talking about I can't do this or this is not right? It's almost rare to see it's a personal opinion of right and wrong. It is almost always a system barrier issue
I
that they
agree.
are going to have to face. And our ask of this simple thing, why don't you do this, is actually not that simple for them to.
So true. I mean, we see that, in policy making, where there's such great ideas and transformative multi-billion dollar efforts. And then those little tiny devilish details, right, will stop the whole thing in its tracks. And I love what I'm seeing in the California landscape around engagement with patients and beneficiaries, engagement with those who are providing frontline services, who really see what's going on at the local level. And I'm very heartened by this new Voices and Vision Council, which is required under CMS, but also is a great opportunity that the state is taking to listen and to invite feedback on things that they're doing or where we're going with things. And I think that's so critical to really strong, sustainable solutions that actually meet the needs of the people that we're trying to serve, but often do it all wrong because we have our own ideas about what we think should work. But we're not listening to the people who really know more than we do, right? And so that's always the question I'm asking of my staff is who are the experts? Who do you need to engage? Who are the stakeholders? Who will stop this in their tracks if they don't know about it or believe in it? Because it will happen. I mean, how many times have we seen technology fail or new programs, services, clinics where we don't know why nobody's coming?
We have this amazing new technology. Nobody's using it.
Yeah, it's so great. What's the problem, right?
I think I was at the Street Medicine Conference in LA at the Street Medicine Institute a couple of years ago. And before that, I'd been at San Isidro. We were in a few meetings over the last few months about street medicine, mobile units. And one comment from the speaker was, don't design your street medicine programs in conference rooms. You need to be out on the street talking to people. That was such it, a realization. We were trying to do this amazing thing through this very complex problem. We were doing in the safety of our conference rooms, often safety of our homes. And in that context, you have to think of healthcare being delivered in a very different setting most people are used to just thinking of the context of who is experiencing the healthcare as a recipient, also who's delivering it is so critical. So you've gone from community mental health, county to health plan. Let's talk about the county. I have some experience at the county. So what was it like working at the county? What did you feel was really great about it? What did you feel was needed?
Gosh, government is not known for being agile and innovative. And so partnering with a physician leader who was conventional and coming from outside the county as contractor, basically, was so great because she was so good. Now she's the director of the healthcare agency and is doing a phenomenal job. It's wonderful to see a physician leader as, the leader of the healthcare agency. They provide services to over 100,000 people every year with the majority of federally qualified healthcare centers. So very strong community health center infrastructure. And what I loved about working with her is she was always looking for ways to creatively work within and around and outside those kind of constraints legally, of course. We're not talking about anything nefarious, but how can we partner with those organizations for analytic support? How can we work with physician leaders to create a standardized system where every clinic is its own entity? This was such a great example to me of those levers that come with decades of experience. Dr. Cho grew up as a medical professional in this organization and was a resident in the family residency program at Ventura County Medical Center. And they have a wonderful family physician residency program. So that was such a great kind of introduction and long lesson, a continuous lesson about constraints and how to work within and around those and be creative to find solutions when it takes 6 months to hire somebody, for instance. Not pretty, but very, very important. And what I think was really wonderful is the insight into local government and serving individuals in the community who are in the, we would say like the most vulnerable kinds of situations, low socioeconomic status, unstable housing, lots of the things that come with poverty and generational trauma and immigration and, all of these things that can really sort of complicate people's lives and create very difficult conditions for health and well-being,
Mhm.
not because of the individual, but because of the system that we exist in and the places that people occupy within the social structure, right? And so I think what was really amazing was being able to have that system level lens, and being able to work with an entire group of clinics, more than 30 clinics. That's a lot to try to wrangle and to do it within the structure because my main role was around the kind of pre-Cal aim Medicaid transformation that was happening in the public hospital systems, which Ventura County is one of them. And so working with the state, working with data and analytics, understanding quality measures and quality measurement and how that can be a tool for transformation and can organize the work that you're doing and lend it sort of a common language and for measuring success and what are we aiming for, what are we trying to achieve, and how do we test change and build work together, among hundreds of people that need to be aligned and moving in the same direction, but also systems have to be flexible enough to be appropriate for the local context because a clinic in Piru, which is population 700, is very different from an Oxnard where we have our largest urban center. So it's really a lesson, I think, again, in humility and creativity. And I love what you said about courage and humility. I think that that's totally true. Like having a conversation with people about asking people for their gender identity who are not taken kindly to that question because it's an offense to masculinity, for instance. Like, why are you asking me? I don't look gay, do I? Like, there's this sort of cultural reality that people are living in. So, how do you sort of do the right thing so that those folks who need to be identified with their preferred and true kind of nature and identity and pronouns that match and all of that goodness with the goodness for the rest of the population who can take that in a very different kind of way. So that's gnarly. That's a big juicy problem to run into. So you learn a lot by running headlong into problems and saying, let's work through it.
I mean, great example. One of the things you said about flexibility of the systems, right? I think is so critical because you do, as a leader, I think you want some standardization across your programs and clinics. At the same time, the clinic and the team needs buffers or flexibility even down to their day. The kinds of patients walking through the door are so different and have so many different needs that our system should be able to expand and contract a little bit, which is, I mean, I've not seen a lot of that, unfortunately, but that's kind of the adaptation we need, I think, and that can be created through creative templates, creative staffing. There are many ways to do it, but it's not easy to do though.
No, it's not. Not at all. Not at all. And I think that's where my appreciation for two kind of frameworks really comes in. One is the model for improvement and testing change and that rapid cycle change and organizing the team and all of the good stuff that comes with that and the opportunity to pilot. And then marrying that with the human centered design methodology and framework to really make sure the right stakeholders are involved. We have the right information. We're not going rushing to a standardized solution and spread without really understanding how people are interacting with this new product service. So I can see that happening in two of the things that I've been working on more recently in the last several years, one of them being follow up after emergency room visit for either a mental illness or substance use disorder concern, commonly known through two HEDIS measures as FUA and FUM. And then also the perinatal substance use project that we're working on. And seeing how working with group to formulate a pilot and to test those changes and to really understand the system has given us the opportunity to create much stronger interventions across the entire system. So, as an example, working with our public hospital, so VCMC, working with our delegate force non-specialty mental health services, working with our county behavioral health department, and pulling all of that together to say, how can we solve a really difficult problem? It includes data exchange and figuring out who needs the services that we're trying to provide, what kinds of services, how do we get people to longer term treatment, whatever it is that they're needing, whether it's at the, primary care level or at the specialty level and, residential medical detox, all of these other things that are pretty intensive. And so having the opportunity to formulate that team, and what I really love is one of the community-based organization that we're working with, Conejo Health, their COO, Ian Anderson, had said, described our group as democratic. It was a democratic process to figure out, what do we want to test? What comes first? How are we going to know if this is a success? How will we know if we want to continue what we're doing? And so having that very focused collaborative group and having the structure that we were engaging in with the support of the state and with the Institute for Healthcare Improvement, what I learned was working with, for instance, this particular community-based organization who's doing the navigation on site at the ED, contracted with them for community health worker services, expanded that to enhanced care management, which allowed them the sustainability and the opportunity to grow versus this, remember the Cal Bridge program for navigators in the emergency room for substance use, and then the funding was gone. And so working with an organization like Conejo Health, who developed in this pilot a very strong working relationship with the emergency department and the hospital leaders and the folks on the floor, allowed them to then kind of spread and individualize or customize, I guess, the solution for each other hospital that they're working with now. So they're in all of our hospitals, all 9 of them in the county now. And each process, each workflow, each way of getting information about who needs support and who to reach out to is different. But there's a standardization that happens through that relationship with us as the managed care organization and through the collaborative with the hospital and the behavioral health department, so that we're able to then take their expertise, or I shouldn't say we, like, well, I'm not doing anything. They're the experts. They're able to say, we understand, we're aligned with the vision, we want to be a part of this, and then kind of customize, but also, like you said, standardize, but then have the flexibility within each hospital system to do things the way that makes the most sense. That is such an amazing outcome, like, because so many of us have tried and failed.
I think you said I'm not doing anything. That's not true because what you're doing, which is bringing the stakeholders together and making it democratic and appear democratic to all members,
Hmm.
may be the hardest thing to do because there are members who think they're more important than they are, and there are others who feel like they have no voice. And what you're describing is, in my view, a dream managed care plan administrator implementation, which is, let's work with all of our systems that exist both from all the way from higher level of care to lowest level of care and make sure we provide the resources for the patients to transition seamlessly. I'm jealous of Ventura County just because, I see in San Diego County, I think the biggest problem in our system is that level of engagement across the systems and levels of care does not exist. And I feel like it's intentional, you know, like people are either hoarding of patients and there's a scarcity mindset approach that there's not enough. There's so many patients to be served, but this lack of collaboration is really a huge disservice for our patients. That's a great example of how a health plan leader can make such a huge impact. I'm curious now, how did you work with the county about the differentiation of higher level of care and the lower level of care?
I mean, we are very lucky in Ventura County because I feel we're sort of the Goldilocks size county. When I was at county, I developed relationships with county behavioral health, and I was grateful to have experience like the leadership program that the county puts together, which is across all departments. So I got to meet people who were leaders in probation, a sheriff's office, human services agency, child welfare, under that. It was just such a great opportunity to meet people and get to know them and be able to say, hey, I have a problem or I have a question or I'm trying to get a hold of somebody. And so those relationships are so critical because it was during the pandemic that I started working for Gold Coast. And so it was basically turn in one computer, pick up another one, go back to my home office. It was a weird kind of first day thing. And I was still meeting with all the same people I had been working with because the healthcare agency is half of our Medi-Cal members. So, it was an expansion of the group of people that I knew and got to know and was working with, but also was very much based on the relationships that I already had. And so I think having that relational mindset and approach, like relation first, is so important. And so one of the things that we've reflected on with county behavioral health is how we already had, good feelings about each other more or less, right? Like nobody was like unfriendly, but taking the time to really get to know each other and structure the time that we have together and structure the work that we do together has been enormously helpful because I remember sitting down, and this is at the collaborative, the behavioral health collaborative that DHCS and IHI had put together. So we sat down at this first person thing and, started just talking about data. Oh, well, wait a minute. So how do you measure that? Well, who are you actually responsible for? Well, how do you get that information? How do you know who's a Gold Coast member and who's not? And then, oh, what does our population look like? We have this kind of overlap, and then these are the differences. And so it was just such a, I can't describe the nerdy level of detail that we were getting into, but it was really helpful because it explained the context for some of the things that were bewildering to us about why decisions were being made around, like in a certain framework that we didn't understand and would have if we were maybe differently positioned, say, why are you doing it that way? But when you understand the framework, the context that people live in and work in and what their mandates and everything are, then you really are able to forge a better relationship. So that was, I think, so key to the work that we do together and are able to continue to do together.
And that speaks to leading with curiosity instead of judgment. Anybody who's not doing the work in what your view of doing it correctly is, almost in 99% of the cases, doing it not intentionally that way. But most of our health systems are under-resourced, underfunded, understaffed. So they've figured out what is working for them. And just understanding that goes such a long way in building that relationship. I'm in the Behavioral Health Advisory Board here in San Diego. And I asked our county leadership, what if you just called a meeting of all the CEOs of all the major health systems in San Diego? And there's reluctance driven to that. There is a shortage of providers. Absolutely, I agree with. But there's also an artificial shortage. The fact that your community health workers, your ECM program managers, are supporting several systems. Not they're supporting the patient, but they're supporting several systems. It goes a long way in helping those systems work well. I was looking at your dedication to keeping on growing and keeping on learning is just like incredibly impressive and inspiring. What have you like? How have you kept up with it?
I think it's an interesting question, and I'm pondering because, I'm thinking even back to where we started, which was in childhood, and being a person who was interested in a world outside of my own. And for some reasons that are a little bit heartbreaking and for some other reasons too. And I'm so glad that I'm endowed with whatever capacity or driving force for curiosity and wanting to understand. And maybe part of it is driven by, what I think we commonly call imposter syndrome. Do I really belong here? Have I really earned my spot? How do I keep earning my spot? How do I do better? But I don't know that that's necessarily an individual shortcoming. I think that it's great to have that mindset of what don't I know and what's important for me to understand and to know. And then the other thing being that, this is a society that has lots of messages that are less than encouraging for most of us because we don't fit a certain mold of leadership. And so when you don't see yourself in that leadership cohort across organizations that you are in and that you see and that, in the media, that you kind of go, well, I guess I'm not really supposed to be here. So how am I going to be here? And I'm just grateful that I have that orientation towards curiosity and wanting to understand. And a lot of it is maybe built out of frustration of, well, why can't we do this?
Yeah.
What's keeping us from that? And how can we make that happen? And so understanding the healthcare system is incredibly important to me. And also, I probably drive my team crazy because I'm always sending them things that I think that they should understand. Because if you know the levers, then you have enough data and you understand how things operate for constraint and also how they can be kind of broken apart, then that gives us the leverage and the opportunity to say, can we make a change here that will then allow sort of a downstream effect so that we can do something differently? So, as an example, understanding more about the community health worker benefit, which is not under my purview, but understanding what it is and how it could be leveraged, understanding data and analytics and HEDIS specifications, which are so specific and weird. If you're inside of it, you talk a completely foreign language, and everybody outside goes, I have no idea what you're saying. So if you understand, oh, if I can meet the measure this way through these service codes from these types of service providers, and that aligns with getting reimbursed for community health worker services, we've got a winner here because now I can prove that this is working through the quality measurement and meeting certain benchmarks that we have to meet, or else, we lose money and blah, 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 and all these other things. But also, that's the sustainability for a community based organization to be able to say, I can be in this with you. I can be a partner. I can take this role because I'm going to get paid for it. And community health worker services, no secret, not great rates. But then how can we leverage that for enhanced care management and, create a more robust system where the people who need the most intensive support are getting it from the people who have a heart for the work, mission, they listen, they're humble, they're creative, they're willing to be in it and struggle through, the red tape and the, everything else that we go through on the public sector side.
Right. So many times I've been told this is how it is done and there is no better way. Again, asking the dumb questions. I think they're the smart questions, firstly, but everybody should be asking those dumb questions because there's probably four other people in the room who don't know also.
Yeah.
I think like the moment a leader says, I know everything, I have all the answers, that's already on the decline, by the way.
Yeah.
Also, you're putting yourself in positions that you don't know everything. I'm on this journey of building a consulting business for myself. I have had imposter syndrome now after many years. But I keep telling myself that this pain is good.
Pain is good. It's
It's
healing.
like, it's a dumb question. Talk to people and learn about it. And then so it's a little bit better.
I like the way you're framing that because why am I putting myself through this pain? And it's true. This desire to make change and to have an impact, I think, is such a driver for, I think, everybody who I've met at CHCF, who's been in a cohort or, faculty, et cetera. And I'm so grateful to be surrounded by people who are willing. We put ourselves in painful positions so that we can make a difference because the more we know, the more we can do, the more we can achieve together. And that is brave, I think. To say, I'm going to venture out and do something I'm really uncomfortable with. And I know I can figure it out one way or another. And if it flops, then it flops. Like, I'll do something else with those skills and that experience that I have because the work really matters. What we do, what we achieve, what we spend our time and resources on in this short life really matters.
Let me ask, what advice would you have for somebody who's early in their career in healthcare?
Yeah, the first thing that comes to mind is what you said about courage and humility. That's such a great formula or, kind of guiding, two guiding words that can allow so much more growth and so much more impact. And that relationships really are so important and not shying away from the hard things. I think that that's really pretty critical. And I think also one of the other things you said is important, which is asking the quote unquote dumb question, because often those are really the smart questions. There's somebody who's thinking about it from a why? Like, are you sure we can't do that? Or why is it the way it is? Or what are the opportunities? Or are we sure this is all we can do? Often those dumb questions come from that outside angle of critical thinking about what exists today and the limitations or the assumptions that we make when we've been in the work too long, when we start thinking, this is the only way to do it, right? And I look at people's innovation and creativity and I go, God, that's such a good idea. But you're so like in the system the way it is that sometimes it's almost impossible to see things differently, which then is so important about finding out who the experts are. Like who is experiencing something, because every patient I've ever talked to and every patient I've ever been in every situation can think of a lot of ways to do things that the people who are providing that care or creating the infrastructure to provide care haven't thought about or haven't figured out how to do. Because when you are experiencing it, when your loved one is experiencing it, you really know. Don't ask me this question when I'm in the emergency room and I can't speak, because the condition that I came in for is creating such an issue for me to communicate. You should have my records at hand. You should have my name and my, insurance ID and all of that. It should be a click and then there you got it. Here's the imaging, here's the medication list, here are the problem list, here are my diagnoses, here are my allergies. You should have that going in so you can save my life. Like, it's so clear when you're the patient, and I think really clear when you're the physician too. As an ED physician, you wanna do the right thing. As a nurse, you wanna do the right thing. You wanna make sure people are not suffering. You wanna save lives. But if you don't have the information you need, and this is like running head first into gnarly problems, like data exchange is one of them that just won't leave me alone. And I can't seem to leave it alone because it's so important. And it's such a crazy important factor in the constraints of our healthcare system and the things that we need to do differently. And it's just so challenging to come up with solutions that work.
It's both exciting and sometimes exhausting thinking about.
Yes, exciting and exhausting. I feel like we need a t-shirt.
I was thinking that some of these meetings I was in, the results I saw 2 years later. And I was in meeting after meeting of just hitting my head. Also, culture change, all of that takes time. And also, I'm thinking the dumb question is critical because you're within the system that has those terminologies. It is so generic for you as an insider that you made an acronym or you just like walk over it and everybody knows. So that probably is the most critical piece of the information in the whole thing mentioned. It is so critical to ask those questions because that really gives you the full picture. Okay, so let me ask you the last question. What is your most challenging and your most exciting project you're working on today?
Oh my gosh. Speaking of data exchange, right? So you think working through the lens of that follow-up activity, right? How do we give good linkage, referral, care for those who are in a critical moment in their lives where things are bad enough that they ended up in the emergency room for one reason or another, behavioral health related. So that necessitates collaborative work. It necessitates data exchange and solving these really nitty gritty problems and issues, file formats, just things that are really not very exciting. Like they're really frustrating because, for instance, we had a hospital that just changed their EHR, their electronic health record, and it broke the report for the daily census. And we just cannot make traction to get it back to what it needed to be. And so this means that, a number of people were not identified in the emergency room or near after the emergency room visit for which they need support. So that's heavy on your soul. These are people who are falling through the cracks because of a data issue. That's infuriating. Let's fix this. But it's so specific and it creates this need for very specific knowledge and expertise and work. And when you have in mind the person who is or is not benefiting from or is being harmed by this, nitty-gritty file format issue with columns and dot delimited, comma delimited files and all this nonsense, that is having a real impact on a number of people's experiences in and after the emergency room and can lead to horrific outcomes or amazing outcomes. One of the most amazing things that I like kind of hold in my heart and in my mind when I'm, talking to a hospital system about their data formats is the stories of the navigators. from Conejo Health. Frank Conway is one of the navigators who's now directing the program for Conejo Health and has these amazing patient stories that every time we talk about our work, we talk about the patient impact and the patient story. So he'll describe how, someone came into the emergency room 8 times over the time that he was there at the hospital. And they're like, there's Frank. And Frank's like, here I am. Can I help you today? What can we talk about today? And just creating that rapport and that non judgmental presence eventually on the ninth time created the opportunity and the space for that individual to say, you know what, I need some help. And has been sober for now, it's probably been more than a year and is working for a health insurance company. I mean, that's incredible to me to go from emergency rooms so many different times to I'm sober, I'm employed, I'm, functioning in life and I feel good about myself and what I'm doing in this world. And that to me is everything. When you get into this work, even if you're in data, even if you're in, finance, even if you're in these administrative capacities, you're not a clinician, I have found that every single person is here because they want to be doing this work. They're supporting it, they're leveraging it, they're being a part of the solution. And so when we anchor our work in the people who are benefiting, hopefully, from the work that we're doing and in partnership with the people that are being served or should be being served in a way that works for them, then you create these teams, of support. And so, when your CFO is thinking, gosh, cash on hand is such a, an issue today, right? That doesn't negate the fact that she is here in a public entity doing work for less money than she could be doing for a Fortune 500 company because it matters to her. And so when we tap into the why for the people who are doing and supporting the work, then it's always exciting, even when it's infuriating, exhausting, frustrating. And so knowing that there were more than 1,700 new in-person ED on-site services for health navigation for people with a behavioral health concern in 2024 because of the work we did. That keeps you going.
You beautifully said, I think healthcare needs to broaden its view of the impact it's trying to have.
Mm.
You described as a system where you're not just talking about serving that patient in a short term, immediate support. You're talking about let's get them to their version of the best life.
Mhm.
Is that I want to, stop using alcohol or get better with my depression. And I want to get a place where I can live and a job, looking at what they want to do. It's I think, such a reframing of health. Lucy, it's a pleasure to talk to you always. I'm so happy we could talk today and learn about your journey. And it's incredible. The work you're doing to bring people together is, I feel, one of the hardest things to do in healthcare, which is, I think, hugely impactful.
Thank you, Gaurav. It's such a pleasure. Love talking to you. It's just been such a delight being able to just have a long conversation with you. I think that's great. So thank you for the opportunity.
Thanks so much, Lucy. Take care.